Yeah, so thank you for highlighting, research, a recent research letter we put together. Basically, we wanted to understand what the, genetic testing rates are in the US for patients with metastatic castration-resistant disease. So we went after or tried to describe that better using a large national database called Flatiron. And we went over 9 years of, between 2014 and 2022, to really understand genetic testing specifically for homologous recombination repair genes, so HR. So we went, understanding a little bit about, number one, how often were providers ordering HR testing for patients with MCRPC. We were also interested in looking at the timing of that testing in regards to diagnosis of MCRPC, because the perception we're having is, a lot of the patients were getting it maybe too late. And so we're trying to understand if there are trends, towards earlier testing. So we did that too. And then finally, we were able to associate, HR testing with important, in our opinion, important disease and patient and demographic characteristics of interest. So overall, that's what we did. We found that testing is getting a bit better, but it's still around half of the times patients do not get tested. It appears that providers are considering testing their patients earlier over time. And we still see, we note disparities in regards to testing that are kind of known from other studies. And I think, our research kind of, seems to be in line with what we suspected in some cases and others have shown before. So, and I think we need to do better from that perspective as well. HR are known to be both prognostic and predictive. Prognostic because particularly BRCAs, but prognostic because patients do not well, irrespective of the treatments they're on. So these are patients that tend to be associated with more aggressive disease, with more metastatic disease up front, who tends to progress quickly on the medical therapies we have available for them. HR alterations are also predictive because they can increases the chances of success of certain biomarker-based therapies or HR-based therapies, namely, or for the most part, PARP inhibitors, although it appears that it might be also true for platinum-containing regimens, for example. But for the most part, where we have most of the data and more, support data around PARP inhibitors in the context of HR-positive disease. I should say it's not unique of prostate cancer. We know this for other solid tumors, like, ovarian cancer, pancreatic cancer. And so, it's, we have that data showing that predictive value of HR testing. So testing for HR, helps to identify patients who are known as like poor actors, but also patients where open the door to the ability or to the opportunity to offer, precision oncology. Yeah, that's, so we went back to 2014 because, we were thinking the rationale for that was, that's precision oncology have emerged in the last decade or so. So we were doing here and there for other reasons, not specifically because we had therapies approved in prostate cancer. And then we got, we started getting therapies approved based on genetic alterations, such as, a PARP inhibitor, also immunotherapy. So I think we're seeing the rise over time is a consequence of that. As you pointed out, I think the peak, as you call it, in 2020 is probably a consequence of the approval of olaparib in 2019. And so usually there was a buzz at that time that, for the first time we have a prostate cancer specific approval for patients who are HR positive. So I think that's the effect of that approval. And then we kind of see a plateau, it drops a bit, in the subsequent 2 years. I think that's probably related to, as you said, COVID and the pandemic. A lot of the providers are either we're not able to see patients or we're seeing it remotely, as those options start picking up. So, and it's not as easy to conduct genetic testing under those cases. So I do agree that COVID probably played a role. I don't think it's lack of awareness. I don't think awareness went down. I really think we see the peak a little bit after the approval of the first PARP inhibitor, and then it kind of plateaus. It drops slightly. It's probably not as meaningful, but we don't continue to see a solid rise. I would think that if we were to do the same analysis now, including 24 and maybe 2025, I do believe we'll start seeing a rise again, because the sense that I'm getting is there's with the availability of other PARP inhibitors, combined with RPs, for example, I think that's going to create more buzz around the importance of finding HR alterations for those therapies, right? Because we have approvals that are restricted to specific HR, right? So I think all that it's probably going to change the shape of the curves as we move forward. Yeah, so one of the aspects that, I think our project was important is to highlight some of the factors that are definitely associated with lack of genetic testing, right? And you pointed out some of them, the socioeconomic status, also the type of insurance, in addition to age, in addition to, race, we highlighted, African Americans, it was better represented in our groups, but also being treated in the community practice. All of these were associated with a lower chance of getting tested. I think there's many reasons for that. I mean, when you look at the barriers for genetic testing, I think cost is still one, whether that's real or not, or is a perception of being a problem. The reality is, in our conversation with the community folks, we do see that come up as a common topic why folks are concerned about ordering tests. So we would see that link. People would have lack of or lower socioeconomic index. Maybe there's some concerns about whether or not that would be covered. For example, in places where you tend to test less, like in a community compared to academic centers. I think those are all connected, and you would explain why you would see those changes. I think when you look at academic places, like you don't tend to see as much of that. Like, when you look over genetic testing data and academic centers, one center, you don't quite see those disparities, and maybe because you're already selected to get there, right? So, so I think some of these factors are associated with one another. And so ways to overcome this, in addition to, of course, raise awareness, there are certain programs out there that actually there's no cost for genetic testing. Most of the genetic testing today is fully covered, by the way, and the more we minimize the obstacles, so we raise awareness, we explain what germline means, what somatic testing means, how they get covered. We probably should minimize also the burden, right? Like in community, a lot of the care teams tend to be, I'm not going to say busier, but they do provide a lot of patient care for longer hours and maybe the number of patients they see. In academia, some of the providers are actually protected, right? So, so if you think of those things, it's hard in a clinic that's busy for you to actually take the time and order the test and follow up with the results. So I think ways to minimize those barriers are probably going to bring us to a point where we're going to see less of those factors playing a role, and we're going to minimize those disparities in genetic testing, in my opinion. Right. So the first thing I would say is, genetic testing is standard of care, right? It allows us to one understand and to make better predictions about how cancer is going to behave because of the prognostic role that we discussed earlier, and also allows us to get access, or patients to get access, to other therapies that would not get access if we're not able to test them, right? So that's one. The second message is, from the study is you can see the trend towards earlier testing. It's a good one. That means that providers are starting to think, I'm going to do it sooner because I can do something about it, and not save that for like too late in the game, where then you need to wait for those results. And a lot of times you end up not acting upon the results. So that trend is a good one. The fact that we're seeing them being tested early on, even before development of castration-resistant disease. So that's good. I think for all the key players, understanding, where you are at a higher chance of not getting tested is relevant, right? I think we mentioned like older patients, community practice, types of insurance, because I think we can develop and come up with target programs to actually look at those groups of individuals and being able to change those numbers and change those statistics, right? People are not numbers, right? But I think if you target there because you understand what the problem is more obvious, I think we can do better. I also think that over time, as we get more biomarker-based therapies shown to be helpful for patients, I think that overall education level and awareness will going to continue to increase. And I think we're going to be, we're going to follow what has been happening in breast cancer or even lung cancer. I would say we are behind those areas, right? I think we have a lot to learn from our breast cancer doctors, colleagues, from our lung cancer colleagues and friends. So I think we'll get there. It's just going to take time. And I actually would think some of the successful programs, like that was being done in those other cancers, can be applied to prostate cancer, right? I'm thinking, for example, reflexive testing is not easy to do in prostate cancer, right? Because it takes a long time between surgeries or biopsy and sometimes an advanced setting. But certainly, we can certainly copy and borrow good ideas and good programs that were implemented in other cancers, for our area, and see if we can improve things that way. But I am optimistic because we do see that trend, and I do believe the trend will continue to go in the right direction. And so we just have to work together as a community to, again, explain for those who are less familiar with it about what is genetic testing, what's germline, what's somatic testing, why it matters, what do you do about the results, and I think the way we're going, it's in the right way. We all want to expedite where we're going to be probably 5 years from now. But with that said, I think we're going the right direction.